One of the most common symptoms for which patients are referred to gastroenterology clinics is gastroesophageal reflux disease. The typical symptoms are heartburn, acid reflux, chest pain and regurgitation of food back into the throat and mouth. This is a miserable condition and can seriously affect the patient's lifestyle. Supine or nocturnal reflux can affect the patient's sleep pattern and so affect their ability to continue their normal working routine. The most significant developments in gastrointestinal investigations over the past few years has been the ambulatory pH recorder. This has allowed quantification of the time during which the esophagus is exposed to gastric refluxed material. The aim of this programme is to describe gastroesophageal reflux as a symptomatic problem and to demonstrate the practical aspects of performing ambulatory pH recordings.
Everyone has occasional reflux of gastric contents into the esophagus. It is a normal event and generally causes no problems. On swallowing, contraction of the muscle walls of the esophagus push the refluxed material back into the stomach. The time taken for this to occur is described as the clearance time. Stomach contents are usually acidic. This is due to secretion of hydrochloric acid from the parietal cells housed within the gastric glands in the mucosa of the stomach. A layer of mucus secreted by the mucus glands within the stomach wall cover and so protect the stomach wall from damage by the acidic gastric contents. Hydrochloric acid plays an essential role in digestion. First, pepsinogen, an enzyme secreted by the chief cells in the gastric glands, is converted into its active form, pepsin, when exposed to an acidic environment. Pepsin is essential for the breakdown of dietary proteins in preparation for absorption in the small bowel. Secondly, the acidic environment also helps to kill off microorganisms, molds, and fungal spores ingested along with the food.
Acid is a normal secretion for the human stomach, and everything usually functions perfectly well without any awareness of the acid.
Patients describing the symptom of heartburn may have reflux of gastric contents from the stomach into the esophagus. This may occur very frequently and remain in the esophagus for prolonged periods, giving rise to the burning sensation in the chest. Some may describe the condition known as water brash, which is metallic-tasting liquid regurgitating from the stomach into the back of the throat and mouth. Problems arise when excessive acid is produced. This breaks down the mucus barrier and may cause direct damage to the stomach lining, resulting in inflammation and ulceration. Also, poor stomach emptying can result in increased gastric pressure, increasing the risk of gastric contents spilling back into the esophagus. The esophageal lining is then exposed to an acidic environment more frequently than is normal. This leads to inflammation and ulceration known as esophagitis. At the bottom end of the esophagus is the lower esophageal sphincter, a zone of high pressure resulting from increased tone in the muscle walls at that level, and compression by the surrounding structures, such as the diaphragm. This high-pressure zone, which is usually between 3 and 5 centimeters in length, provides a barrier limiting the reflux of gastric contents into the esophagus. If the pressure becomes very low, then the effective barrier function is impaired, and reflux may occur more frequently. In some cases, the fundus of the stomach moves through the diaphragm, giving rise to hiatal hernia, which also decreases the effectiveness of the barrier. Once esophagitis is developed, the patient may complain of discomfort on swallowing as the ingested bolus moves past the inflamed area. They may describe increased sensitivity to acidic or carbonated liquids or be temperature sensitive and unable to tolerate hot or cold food or drink. Some patients with severe reflux disease may develop a condition called Barrett's esophagus, in which the lining at the lower end of the esophagus, which is normally squamous epithelium, changes to columnar epithelium, as found in the stomach. This change in structure appears to generate an increased risk of further cellular change into malignancy. Chest pain is a common symptom and may be confused with angina. The location of the pain sensation is similar because the sensory nerve pathways from the heart and the esophagus have a common pathway to the spinal cord and then to the brain. It is important to investigate these patients to determine if the cause of their pain is related to acid reflux, as there are other causes for these sensations within the chest area.
Patients referred for pH studies should have already undergone endoscopy or barium swallow to exclude an organic lesion as a cause for their symptoms, or may result in traumatic injury upon intubation.
Ambulatory pH testing allows the detection of the changes in intraesophageal pH over 24 hours. This will allow the investigator to determine the frequency and duration of esophageal exposure to acidic refluxed material. When the intraesophageal pH drops below pH 4, this is described as the onset of a reflux episode. The episode is considered ended when the pH returns above pH 4. During the test period, the patients will follow their normal routine with regards to meals, activity, and sleeping. Diurnal variation in acidic production occurs, so it is important to have as long a period of recording as possible. We will now go through the equipment required and the procedure for ambulatory pH recording. Single-use catheters are available and provide significant convenience. Options include internal or external reference electrodes and infusion ports for manometric catheter placement. The Digitrapper is capable of recording up to 4 channels of pH and a single channel of pressure for manometric catheter placement. Power is supplied by 2 AA alkaline batteries, which when inserted will automatically start the unit. Fresh batteries should be used for each study. A flashing green LED indicates the unit is functioning, even when in power save mode. Designed to make patient symptom reporting easy, the event button is used to indicate the onset of a symptom, for example, heartburn. By providing visual feedback, the period switches help the patient to reliably indicate both the onset and end of meal and recumbent periods. Electronic diary information entered through the use of the period and event buttons is captured along with pH study data. The operator control keys are used to control the unit's menu system. They are concealed to prohibit patient access. You will only need to use these keys occasionally. For more details, consult your daily use manual. Displayed on the screen are various operator and patient instructions dependent on operation mode. The study data is transferred to the computer via infrared communication, either through a built-in port or using a dongle attachment to the computer's serial port. The recorder must be calibrated before each new patient study. Calibration ensures that the system, both the recorder and the catheter, is accurately detecting the pH value of the environment. 2 buffer solutions of pH 7 and pH 1 are used, as these represent values at either end of the pH range normally encountered within the esophagus. Make sure that each of the sensors and the reference electrode are immersed in the buffer solution. The unit will now check the catheter function. Once stable pH values, firstly from pH buffer 7 followed by pH buffer 1 have been obtained, you are ready to begin recording. Discard the used buffer solutions after calibration. Contamination of the buffer solution should be avoided, as this can create calibration problems and potentially inaccurate results. The most common calibration problem is catheter failure. Multi-use catheters can only be used for a limited number of studies. The usage is mainly dependent upon the degree of acid exposure. Immediate and thorough cleaning will limit the buildup of organic debris over the pH sensor and maximize sensor life. For single-use catheters with internal reference electrodes, make sure you have removed the cover protecting the reference. An appointment letter will be sent to the patient, requesting them to fast at least 6 hours preceding the appointment time. Also included will be a description of the procedure, and in most cases, the patient will be asked to stop taking anti-reflux medication several days before the test. This is generally 48 hours for H2 antagonists and 7 days for proton pump inhibitors. During the procedure, it is common for the patient to be requested to limit or exclude certain foods or liquids from their diet. Alcoholic, carbonated, and acidic drinks should ideally also be excluded because they have a profound effect on intraesophageal pH. When the patient arrives, the relevant clinical history, medication, and symptoms are discussed. The procedure is fully explained to the patient and informed consent obtained. If the patient has a known cardiac or respiratory problem, then it is advisable to monitor the patient's heart rhythm or respiration during the procedure. Most patients will feel very anxious about the procedure, so the procedure should be performed as quickly and skillfully as possible. Begin by anesthetizing the nostril using a minimal amount of local anesthetic, either spray or gel. This will take several minutes to take effect. Care should be taken to avoid inadvertently anesthetizing the esophagus. Lubricating gel is helpful to aid the passage of the catheter. The pH catheter is placed carefully through the nostril and into the pharynx. The patient is instructed to tilt the head forward and to take sips of water through a straw to relax the upper esophageal sphincter and so aid the passage of the catheter through the cricopharynx and upper esophageal sphincter. Insert the catheter to a depth of approximately 60 centimeters. If you are using a catheter with an external reference electrode, attach it to the patient's abdomen or chest now. It is important that a good contact is made between the electrode and skin, otherwise artifact will corrupt the data. The skin should be cleaned, electrical coupling gel applied to the electrode, and the reference should be well secured. The normal range of values determined by DeMeester showed that normals had less than 4% acid exposure at a site, and that this was therefore a good position to separate the normal from abnormal reflux values. The distal esophagus is most affected by repeated exposure to acidic refluxate, as the acid is often cleared from the esophagus before it migrates into the proximal esophagus. For a standard single-channel pH recording, the sensor is positioned at 5 centimeters above the proximal border of the lower esophageal sphincter. If the location of the lower esophageal sphincter is known, then the pH catheter can be withdrawn so that the sensor is positioned 5 centimeters above the proximal border of the lower esophageal sphincter. To ensure that the catheter is in the stomach and not curled up in the esophagus, check that the reading on the unit's screen is less than pH 2. The catheters are generally hidden beneath the patient's clothing so that they are out of the way.
We want you to try and eat and drink as normally as you can during the test.
Before starting the recording, diary record keeping is explained, both the electronic and the written diary. Electronic diary events are entered using Digitrapper's period and event keys. Further information about symptoms and meal times are recorded in the written diary using times read off the Digitrapper internal clock. To activate the clock, press the small blue button immediately below the screen. Specific instructions about diet, medication restrictions, and return time should be on the diary card, along with any other important information. Emergency contact numbers should also be included. This may be the department number and hospital switchboard, so that if a problem arises out of hours, a member of staff can be contacted. The recording can now be started, and a note made of the starting time. To verify that the Digitrapper has begun recording, check the unit screen. The Digitrapper will eventually switch to power save mode if no buttons are pressed. Pressing any button will reactivate the display. The following day, the patient returns to the department for removal of the catheter. The Digitrapper is checked to make sure it is still working and recording accurate values. If the predefined protocol time has already expired, the unit will be switched off. Stop the recording, and remove the catheter with care. After the patient's diary sheet is checked, the procedure is ended. When a multi-use catheter is used, it must be washed immediately in detergent and warm water, dried, and then placed in a sterilizing solution, such as glutaraldehyde, for the indicated period, generally 10 minutes. Care must be taken not to wet the connector. The reference electrode and lead can be washed, dried, and then wiped over with an alcohol swab. Sticky residue from the tape can be removed using acetone or something similar. Finally, rinse the catheter thoroughly in water to remove all traces of sterilizing solution, dry, and store, ready for reuse. The patient's demographic and diary card information is input to the system, and the pH data is captured by the computer system via an infrared detector and the automatic analysis performed. It is important to review the entire procedure to check for any possible loss of signal or artifact. Signal loss can be caused by a loose reference electrode. Next, review the data tables for correlation with the raw tracing. The period table includes the following useful information: frequency of episodes of pH less than 4, duration of episodes, as this reflects the clearance ability of the esophagus, total time, pH less than 4. Correlation with events, such as eating, occurrence of symptoms, and body position, that is to say, supine or upright. Printouts of the data in graphical format are useful and provide more visual information than the data tables alone. The report should include the patient's details and reasons for referral.
I hope you have found this program useful in providing information on how to undertake ambulatory pH testing in patients with symptoms of gastroesophageal reflux disease. But to ensure the accuracy of your data recording, it is important to remember that new batteries must be installed for each new study. Verify that you have selected the correct study protocol for that patient. Calibration signals from each of the 2 buffers is essential prior to every study. The manometrically determined LES location should be used for positioning the pH sensors. Measurements from gastroscopy or the pH gradient methods are highly inaccurate. The compliance of the patient with the dietary and medication restrictions will be better if the patient is given an explanation of the reasons why they are imposed. Completion of both electronic and written diaries is important for accurate interpretation of the recorded data. Therefore, if these recommendations are followed, then the data acquired from the ambulatory pH testing will provide clinically useful diagnostic information that will be used for the successful management of the patient's reflux condition.